This is the 21st show of the AAHPO Town Hall. Tonight, we have Dr. Louis Najarian, but Dr. Najarian is well known to our communities and has done a lot of the seminal work in adolescent care, and we'll be introducing him in a few minutes, both here and in Armenia. So he's intimately familiar with the mindset of our youth and can share with us the impact of a shutdown will have on their learning and their behaviors. And Dr. George Malikian is an adult infectious disease specialist with other degrees in epidemiology, who has treated over 100 cases of COVID-19, is up to date with the literature, has contributed to the literature, and we're so honored to have him with us as well. At this point, I would like to turn the meeting over to really a devoted member of our community, Dr. Celine Kojoglanyan. Dr. Kojoglanyan has dedicated many, many hours of her time, as others have on this call tonight, to share with us the latest in developments and her thoughts on the COVID-19 virus. We're so special to have her in the New York area. She's not only a board-certified pediatrician, she's a board-certified infectious disease specialist. She's an associate professor at Maimonides Medical Center, and she recently contributed to the body of scientific knowledge through a research publication about COVID in children. Thank you so much for joining us, Dr. Kojoglanyan, and what can you share with us this evening?
What have we learned and what are we learning about SARS-CoV-2 and children? We do know that in the United States, the incidence of infection in children is lower than in adults. And what does that mean? If we look at all the tested positive cases, so everybody who for some reason got tested, and so far that reason is symptomatic people. So if we look at all people tested, 7% of those have been children under 19 years of age. Worldwide, that number actually is a little bit lower, is about 3 to 5%. We do know that just like adults, there is data showing that the children can be asymptomatic. And then when they are symptomatic, most of their symptoms are mild. They vary, and they are different from the typical COVID-19 that is characteristic of the adolescent age group and adults. So the typical COVID-19 is the cough, shortness of breath, and pneumonitis. But even in adults, we know that there is also different variations. There's those who just lose their sense of smell. There's those who have mostly gastrointestinal manifestations like vomiting, diarrhea, abdominal pain. Severe illness is far less frequent than it is in adults. So if we take like intensive care unit admissions for children, it's been about 1,000, 1,200 countrywide versus, of course, 300,000, 500,000, 700,000 for adults. So it's definitely a stark difference there. And then you've also heard of the multisystem inflammatory syndrome in children, which is temporarily associated with SARS-CoV-2. So far, it is in seemingly healthy children, and it is a rare but serious complication. And the rate of this MIS-C as compared to regular COVID-19 is around 1 in 100,000 children. So it's a pretty rare condition. And then the focus will be, are children major contributors to SARS-CoV-2 transmission in the community, because that will inform our decisions about opening schools and summer camps and daycare facilities. So this is our publication that Larry was referring to in one of the American Academy of Pediatrics journals. And I just wanted to show quickly, one thing that is common to us and to the national data is that the majority of kids hospitalized with this disease were under 1 year old. So for the school age kids, you know, it's 20%, 20%, 20% equally distributed, a little bit higher in the teenage years, because as I said, in the teenage years, you can have the typical COVID-19 presentation with shortness of breath, pneumonia, etc. And then as you can see, as I said, 10% of our cohort of hospitalized patients was asymptomatic, literally zero symptoms. They were admitted for unrelated conditions, and they were found to have SARS-CoV-2. This is the national data, not the Maimonides children's data, showing you again that 65 and up make up the highest rate of hospitalization with this disease. And then the younger, of course, 18 to 49 also, but the children 10 to 19 and younger are very low. Again, telling you that they're not gonna get sick enough to be hospitalized. Quickly, MIS-C, as I said, is rare. The average age of this disease is 8 years old. It's a spectrum of mild to severe conditions where different organs can become inflamed. the heart, the brain, the skin, the intestines, or the kidneys. And this is a concern of some parents as to how we can safely go back to school. Again, it's all about numbers. And some MIS-C children have signs and symptoms similar to Kawasaki disease, which you see on the right: red eyes, red lips, rash. And here the blood vessels get inflamed. And we're basically treating these patients just like we treat Kawasaki's disease. The symptoms are persistent fever, plus you have to have a known exposure or infection with COVID-19. And of course, you can have a variety of manifestations: vomiting, diarrhea, rash, etc. And again, the good news is, even though this syndrome sounds scary with heart inflammation and stuff, but the majority of patients, I would say there's about 500, 600 kids right now in the country with it. And almost, with the exception of 2, all have survived and doing well. So we have had 2 deaths with this disease. So are children responsible for SARS-CoV-2 transmission, and to what extent? That's, as I said, central to making our decisions. So I'm going to present to you some positive news, and I'm going to present to you some caveats. So the positive news is that there is this paper that came out of Geneva. They had 40 children under 16 years of age diagnosed and symptomatic with COVID-19 back in March when they were having the pandemic. They went and did contact tracing of all their contacts that lived in the same household with them, with these kids. And they found out that the children were the index case, meaning the first person who manifested symptoms of this disease were children, which they concluded that if all the rest of the households, and 90% of the households, it was the adult who had the disease first. Therefore, concluding that probably the child was not the source of the infection, the adult was the source of the infection. Remember, these were all symptomatic people. We don't have data on asymptomatic. Another much, much larger study that just came out of South Korea. This was, they had 5,000 patients that they contact traced. Only 153 of those 5,000 were less than 19 years old. And again, the lowest COVID-19 rate for household contacts was in the children 0 to 9 years old, only 5%. So this was in the middle of school closure. Everybody was at home, and they found that the transmission from 0 to 9-year-old to others is the lowest in this 5,000. I must say that between 10 and 19 was a different story. It was just like adults. So again, more and more data, which I'm not presenting here, I will leave time for the other presenters, show that the 10 to 19 group gets more infected, more severely ill, and more contagious than the under 10 or under 9-year group. I'm not going to go through, another one in Australia claimed that they had 9 students and 9 staff infected with SARS-CoV-2 across 15 schools. They did all the contact tracing, and they only found 2 secondary infections. And then we do know from other diseases that children, because in this disease they are mildly symptomatic, they may have weaker and less emissive coughs. Therefore, they might be releasing fewer infectious particles into the surrounding environment, and that's another reason why they might not be contributing to transmission that much. What are the caveats, the other side, the flip side for us who take care of these patients? Some of these studies I mentioned to you, the Australia one, for example, it was done during a very low level community transmission. So if the chances of having the disease in the community is low, then the school is not gonna, is gonna be the same. It will reflect the community. And as I said, the index cases in almost all the contact tracing studies have been symptomatic cases. So we do not know much about asymptomatic and if the asymptomatic child can transmit to an adult, although the chances of that are very, very low, but we need more proof. And then the other caveat, guys, is that because the school closures occurred along with or before widespread stay-at-home measures, most close contacts became limited to the households. So we do know that in household transmission is about 15%. So we do know contagiousness happens. And what will happen if we go take the kids back to school where there are opportunities for them to be exposed in the community and present as index cases? So that remains to be seen. And then Israel and China, they opened schools normally in May. They didn't do safety measures, and they had several outbreaks well publicized. For example, in one school in Israel, in a middle high school, there were 200 cases. They had to shut down all the schools again. So transmission is inevitable. Risk is not going to be zero. It depends on the measures we take while awaiting for more data. One of the key points, as I said, is the background community-specific virus transmission rate at the time when your school is going to open. So whether it's in New Jersey, Hovnanian School, whether it's in the church schools, what's going on in the community at that time. And two measures that are very important to keep track of is the % positive rate in the community. The WHO and the US have put this less than 5% positive rate as a good number where you can, safely do activities, including going to school. And then 2-week trends are also important. Just as an example, Massachusetts versus Texas, around the same time in June, you had 2-week sustained decrease in rates, versus in Texas, you had 2-week sustained increase in rates. So hints of what's going on, trends are also going to be very important. And this is my last slide. So again, be ready to pause if we have worsening community transmission. The plan has to include closing if transmission increases. The CDC guidelines, we can discuss later in detail during the discussion, but they include obviously decreasing class size, increasing desk space, putting children together in small cohorts, keeping the same cohort of children in the same class, in the same recess with the same teacher, eating their lunch at their desk. Teachers should not be avoiding and gathering in conference rooms. I'm sure George will talk about that, because teachers are as much of a concern in this as students. Masks have to be worn, especially for older children. We have to have plenty of automatic sanitizers and adequate air circulation, because at some point in the winter, we might not be able to be outdoors. I always recommend, and as I said yesterday to some of the people here, that we should always have open and in a window. And Larry, there was a question about maybe what type of filters also some of the schools can buy, which you can hopefully tell them, because you did that for your clinic, which might also help circulate fresh air. It's going to be very important to keep a child home when they are ill. And again, because this illness can be very mild in kids, unfortunately, we have to expand the list of symptoms for which a child should be kept home. And hopefully testing capacity will be good enough that we can easily take that child to the pediatrician, have a test done. If negative, the child returns to school. Gradual reopening is another idea where you can start the school 1 week for the younger children. You work out your kinks, and then you can resume, you can start with older kids and then high schoolers. And of course, staggered attendance, staggered arrival to school, and plan ahead. Like Larry said, it's going to be very crucial to keep ourselves updated with all vaccinations, flu vaccines for all age groups. Anybody above 6 months of age, there is no contraindication to get any flu vaccine, including egg allergy, unless you have anaphylaxis, severe anaphylaxis, severe allergy. And this, the vaccine now, both for above 65 and under 65, this season is going to be quadrivalent, which means it's going to have 2 strains of A and 2 strains of B. So it's going to provide as much protection as possible. And then for older adults, George should also mention that we have pneumococcal vaccine, shingles vaccine. So all these high-risk patients should be ready. And this is something that our colleague Alicia Demirjian, who's also a pediatric infectious diseases, had worked with her colleagues in the United Kingdom. A very cute book that you guys can download for free on the internet. And it will give you how to approach the kids and how to teach the kids about safety measures in a very easy way for the kids to understand, and all the changes that they have to go through.
We are St. Leon Armenian School in New Jersey, and until now we are very worried. We will open our school, we will not be able to open. We do in person, or we do it
Hybrid
by Zoom. My question, we had thought about, and we talked with Erdiran, and we will have a meeting. We will take all the precaution necessary, the temperature, the mask, the sanitizer, washing hands, and of course, being always do 6 feet apart, social distancing. My question will be, if any of the children, they come and they have it, or any parents that they drop their kids, and we have teachers, we are over 60, and they go home, to their spouses, to their family. How can we manage that?
Yeah, so that's going to be a very crucial question, right? As we said, I don't think transmission can be zero. We are hoping it will be zero, but there's always going to be a small risk. no matter what you do. So again, distancing is going to be crucial, and small class sizes. I don't know how big your classes are and how many students you put in each class. So there's got to be ample space between the students while they are in the classroom, and a lot of ventilation so that there is always air circulating. So, and as I said, everybody who is ill, any illness, so a sniffle, a sore throat, a congestion, a cough, mild, which wouldn't otherwise keep a child home, in this season, it's unfortunately going to have to keep the child home. And then the reason why we're keeping all the cohorts together, so let's say you do have a class of 10, they're together from morning to night. They are not interacting with any other children, neither in recess, nor in an auditorium, nothing, right? So God forbid if one of the kids has the disease, you're going to have an easier time to trace the other 10 kids in the class, with the teacher, and the teacher at all times has to wear a mask. And for the younger kids, because they might not keep the masks on a lot,
we have kindergarten,
has to have the goggle or the face shield. So always the teacher also, there is no more walking in between the aisles, right? She has to stay way away from as much as possible from the children. It's going to be tough.
By June 2020, more than 20 countries have opened their schools, and some countries, including Taiwan, Nicaragua, and Sweden, never closed their schools to start with. In the United States, it's about 6% are those 18 and under, and a third of those among children are between the ages of 10 and 18. So a very small proportion of COVID positive is among children. So the question is really two things that we're talking about. One is, what is the risk to a child if a child is infected with COVID? And then number two is, what is the secondary risk into the community with opening schools? You know, that would be about transmission from child to child and child to adult. As far as the first question, we have tons of data on that as far as the severity of illness when it comes to children, and that's very reassuring. Children do really, really well. I'll go over some of this data that really supports that. And as Tony has said previously, the data about what's the risk of children transmitting the virus to each other and to adults, so far, the data isn't conclusive, but so far the data also appears to be very reassuring. This is recent, right out of the oven data from the CDC. Among approximately 70,000 cases of COVID infection in children, or quote unquote children under the age of 20. 2.5% required hospitalization, less than 1% required ICU admission, and as far as mortality goes, which any single death is too many, but very, very small. With no underlying medical conditions, it was 6 cases out of 7,300, 0.08%, and 0.74% for children, even with underlying medical conditions. How do children get COVID, and do they transmit COVID to others, which is what we talked about earlier. These studies, Sonia talked about already, so I'll just say basically all of these results show almost no transmission from child to adult, or even children to other children. This is the first study in France. There were 3 cases in 3 different schools, just to cut to the chase. When they did contact tracing, 1,340 people were contact traced, including teachers, parents, and they found no secondary cases of transmission. One thing Sonia also mentioned when we talk about that percentage rate, that secondary attack rate, for those who aren't familiar, that statistic is basically the numerator is how many cases. So in this case, if a child is infected, the numerator is how many additional cases are infected associated with that, for example, that person, that child. And the denominator is all the contacts, everybody that child has had contact with. And there's, you can use definitions that contact would mean you're in close proximity, or, the case definitions vary, but more or less it's designed to capture anybody with any amount of meaningful contact. So no secondary cases in this study. This is the French study. The Ireland study, similar results. They contact traced 6 cases. And these are all, you can see my laser pointer here. These are all the number of contacts that were investigated, 1,160. And number of secondary cases, there was just 2 on one of those cases. And those are a little bit questionable. Is this study, the other important thing I wanted to mention, to keep in mind, is that just because these studies were not about children in school, we can still draw a lot of meaningful conclusion. As Tolin said, there's transmission that happens at home. What's important is we still look at the overall picture, which is these are children who are in contact with other folks in a closed setting, and what's the risk of transmitting the virus to one another. Let me just go on really quickly here. I think Solin already talked about this. In Australia, 15 schools, 2 students were identified as possible secondary cases, and again, both were asymptomatic, and one was found to be antibody positive 4 weeks later. Switzerland, again, this was looking at the dynamics. This wasn't just in school, but out of 4,300 COVID-19 infected patients, 40 were 16 years or younger. And when they did contact tracing in this study, and contact tracing, for those of you who aren't familiar, is basically you drill down, you go home to the home, and you find out who was sick, when the symptoms occurred, and you try. The purpose of that is to establish the timeline. Were the parents sick before the child was the child sick before the parent, and so on. So in this case, in approximately 80% of the households, the source was identified as another family member, an adult. So again, we're talking about transmission from parent to child, not child to parent. And in 3 of the 39 households, the children became symptomatic before the adult. So again, very, very, very small cluster, or a small number of cases. And again, these were all in family clusters, and no evidence of child to adult transmission even in these cases. This is some data from China. Again, same story, 68 cases of pediatric infection, and 95% of those cases, 65 out of the 68, were from household contacts, and no evidence of transmission from child to adult. These were, again, adult to child. And I've included all the references for these papers, and I'll be happy to share those papers with anybody who's interested if you want to review. Don't worry, I'm almost done with these slides. I know this is being repetitive, but I just want to really make the point. This is really pretty much the sum of good data that there is on this topic. Again, this is another study from Singapore. And in this case, it was 3 events, or 3 seating events. There's 2 preschools and 1 secondary school. Very interesting case. In the secondary school, so we have these 3 schools, and they had a child that was positive in each one of these settings. So they did contact tracing in all these schools. So in the secondary school, for example, they found 8 children who developed symptoms, such as cough, fever. All of them tested negative for COVID. And the same was the same in both preschools. Now, right here, 77 children tested in the second preschool, 8 were symptomatic, none positive, and 34 children in the other preschool from the first case, again, all tested negative for COVID. It's a very odd thing. I mean, I don't know what's going on. Solin, perhaps, or likely because she treats children, I don't. If how common these kids get upper respiratory infections or fevers that are totally unrelated, or are they just clearing it and they're not making antibodies? Not clear what's going on, but all negative. This is the last slide I'm going to go to. So Solin mentioned briefly, about Israel. This is an example of some of the stuff we see. So this is from the Daily Beast. This is the headline here. I just copied it right off the internet. Israeli data show school openings were a disaster, and it wiped out lockdown gains, right? So I drilled down the source of where this is coming from. By June, listen, I'll read this out loud so you can see. By June 3rd, there were 200 COVID cases and over 244 positive tests among students and staff across multiple schools. So the government ordered the closure of any schools with cases of COVID infection, and 139 educational institutions were on indefinite closure out of 5,200 schools and 200,000 kindergartens. So we're talking about a very, very small number. As of June 24, isolation and quarantine has affected approximately 1%, oh, it got cut off, 1% of the schools. So you can see how this is different than the headline. It wasn't a total disaster. We're talking about 1%. There will be blips, and it's important for people to keep their finger on the pulse and take appropriate measure, but this is far from a disaster. This is far from a disaster.
Well, that was wonderful. Thank you so much for reviewing what's happening in schools around the world where they have experience in opening schools and the surveillance that goes on and how important the surveillance is. Part of this discussion about what is our definition of safe is what are the alternatives? And there's two alternatives, extreme alternatives with this virus. The one extreme is to ignore all social distancing measures and mitigation measures, and which is foolhardy. You're putting yourself and others at severe risk. The other extreme is to shelter in place and never leave the home. But we know that even though intuitively sounds good and it sounds safe, people were harmed by doing that, by not seeking medical care for serious underlying illnesses. Diseases don't take a vacation. There's been a spike in psychiatric diseases, suicide, addiction, addictive behavior, child abuse, and other things. So that doesn't seem palatable. So what we're talking here is really seeking this balance, and to help us understand that balance, particularly on the psychological impact on the adolescent and child mind. We are so fortunate to have an adolescent psychiatrist with us, Dr. Louis Nigerian.
I'm a child and adolescent psychiatrist. Let me start off on the clinical end. I work with children during normal times who are school avoidant. They don't want to go to school. I have to talk to the kids. I thought the parents, the school psychologist comes to the house, pulls the kids into school. Every kid I'm working with now can't wait to get back to school. The kids want to go back to school. The parents want them to go back to school. And the teachers want to be back in school. Now, I thought initially the question was whether, are we going back to school at all or not? It sounds like the question is, how are we going back? We're going back as hybrids, half in school, half remote learning. And I just want to give you my take on that. 50% of teachers are under 41. 85% of teachers in the country are under 60. So teachers are in the healthy range. The second and really important thing is the teachers I've talked to doesn't work. Kids don't learn remotely. The elementary school kids do a little better because they're into the technology. The middle school and the high school kids, they fool around, they talk, they're able to hack it, they shut it off, they complain about the technology. They don't really learn. That's what the teachers have told me. Now, the spring semester was lost. It's not the end of the world. If we go into the fall semester like this, it has become 6 months, it will be, forget about the educational disaster, it's going to be a psychological disaster on the children and the families. How? They're not going to be learning. They're going to get depressed. They're going to act out. And I think it's going to be a psychological disaster and an educational disaster. The data I'm hearing from Solene and Dr. Malikian is that it's not bad for kids, and they should be in school all day long, all of them, with safety precautions. That's my take and my recommendation. That's what I've done to my school district in Long Island, and that's what I think all schools should be doing, particularly the private schools. In a school like Hovnanian, Sunday schools, Armenian schools with 10 or 12 kids, it would be even easier, but it's even doable in the public schools. If a kid gets sick, he goes home. If a teacher over 60 doesn't want to teach because they're nervous, you give them an administrative position, and or for those kids who are staying home anyway, like a school avoidant, let them teach those kids remotely. But if kids aren't in school, it's going to be an emotional disaster and an educational disaster. And from what I'm hearing from our medical experts, that it's not going to be that serious if they all go back to school and we do it cautiously. If 1 or 2 kids in the world infected an adult, I think we can tolerate that. In spite of what the Israeli study showed, most of the data, the American Academy of Pediatrics, Toronto Children's School, which is one of the leading Toronto Children's Hospital is a leading children's hospital in the world. Europe is open. Sweden never shut down. Their data is no worse than ours. So I don't see why there's any medical infectious disease benefit to going in a hybrid way and we not get back to where it should be. That's my take on it. In the remote learning, kids are fooling around. The ADHD kids and the behavior kids and the depressed kids are getting worse because they're not just buying into it and you can't control them. You know, the teacher's far away and the teacher's on the screen, the kid can play around with it. Some of them do okay, but just okay. They're not learning. How do you do chemistry and biology? And how do you do that? It's not possible. So the kids, whatever problems they had are getting worse. You get an isolated kid. I tell you, the kids have benefited from this. A couple of my patients are isolated kids with no friends. They say the quarantine's fine. I don't mind this. No one's bothering me now. I don't have to get together with anybody. It fits right into their pathology and disturbance. But the greater difficulty is parents are home trying to work, fathers are home trying to work, and they're trying to supervise their kids, and they can't do that. So the kids are getting more disruptive, more unhappy, and becoming depressed because they're socially isolated. They can't do the usual things. Like I've said before, dad can't go golf, mom can't play tennis, they can't get together with their friends, they can't go out to lunch. So they're robbed of all of the opportunities, and keeping the kids home is only intensifying it. I don't know if that answers your question, but it makes everything that was there worse, and it brings on a few more isolated and mood disorders and disruptive behavior disorders. As a parallel, and I don't want to get into politics, but why do you think the country is going crazy? You restrain a free society long enough, they're going to look for an opportunity for the bubble to burst, and this killing in Minneapolis burst the bubble. Why is the country going nuts? Because everybody's been restrained psychologically for an extended period of time, and they couldn't control it. Now that's where it's at. But I know it deviated a little bit, but that's how it's affecting kids too.
I have a question from a student actually, and his question is, how come it's okay to put food in my mouth, but it's not okay to touch my mouth with my fingers or my nose or my eyes?
An issue is really the mucosal membranes of the eye and the nose is really where you're worried about transmitting with the coronavirus. The mouth also has DNAs and RNase enzymes that rapidly dissolve, denature these organisms, so it's less of a risk.
That's not too different from the way it used to be. You know, in the old days, 3rd and 4th elementary school kids stayed in the class from 8:30 to recess time, and then they went out for a half hour, and then they come back. You have to move around in the class. You time out, and then you do a 15, 20-minute recess in the classroom. You sit down and finish your work until it's time to go to lunch. I thought it was one child isolated. You're talking about a class. You can be creative with activities in the class that break up the day when they're not going out of the class, but they're staying busy within the class. That would minimize avoidance or activity. The key is activity. It's not so much that you're in one classroom, it's that your activity is limited. So you've got to be creative to get more activity in that one physical space. You know, stop and think about Africa. 10 kids are in one building, one room, and they got to do everything in that room. The whole idea is to interact.
There is a question from I think the head of Board of Trustees of Hovnanian School. Nazar, if you don't mind, I'm just going to read it loud. How do the numbers we are seeing for COVID transmission in children compare to other diseases like the flu in terms of the risk of serious illness? So how do we explain to parents the risk in a way that they can internalize, and to try to get a good comparison for families between these diseases so they can better understand the risk. So I would say, like we said, the flu is very well established to be a disease of childhood. The flu is very well established to be dangerous to children. As I said, statistically, children under 5 and especially children under 2 have the highest morbidity and mortality with the flu. The reason why we are more concerned about this virus at this point, because number one, there is a lot of unknown with this virus still. Every day we are learning something new about this virus, whereas the flu we have studied, we know everything about it. Number two, the best guesstimate today, it might change tomorrow, next week, next month, is that the mortality rate of this virus for the population, not for children, is 5 times more than influenza. So the mortality rate for influenza is 0.1 to 0.2%, depending on the year. The current fatality rate for this disease so far is estimated to be around 0.5%. So about 5 times more deadly. And again,
but 0.5, 0.5.
0.5. So 5 times more potentially deadly than influenza. Hence, you know, all the measures we are taking. And number 3, I think, again, it's not just about the kids. The kids are going to do well. As I said, my hospital has discharged 3,000 adult patients as opposed to 50 pediatric patients. I took care of all 50 of them, but it's nothing compared to the number of adults. And we were in the middle of the pandemic here. So if kids were going to be sick, they were going to be sick in New York. They were not. We know that. But we are more worried about the teachers. I think it's the teachers who are sounding an alarm. And then the parents, if the child may transmit disease to a parent at home who himself or herself is a high risk, a grandparent, a caretaker. Many families have grandparents who babysit the kids and not the parents. That's really also a whole big chunk of this. To do this safely is not just to protect the kids, but it's to protect their families and the teachers. So here, I think if George can comment on how teachers can you know, what measures should teachers take in school to minimize risk would be helpful.
If I'm a school administrator and somebody comes to school on Monday and has symptoms of a cold, which could mimic COVID, my appropriate response would be to send the student home. And when would we advise them to get tested? Would we wait the 2 weeks, or would we wait the week, or maybe not get tested at all?
If they have symptoms, the chances that they are going to be PCR positive if they have COVID, Larry, are higher than if they have no symptoms. So even though we know that asymptomatic transmission occurs, but we do know that in general, the viral loads and therefore the chances of being detected by PCR are higher when you are symptomatic. So that would be the best time to go and get the test.
The other option that you have, Larry, is the 14 days that you alluded to. That's the incubation period. So that's the time between getting exposed and having symptoms. Of course, with children, this is a much more different population because many of them may be completely asymptomatic. But another option is to ask that person to self-quarantine for 14 days. And I think maybe at the end of the 14 days, you could test it. Or if they're completely symptom-free at the end of 14 days, then it's a very, not 100%, but a high probability that they're not infected.
So thank you very much for a lively discussion. We heard about some of the issues related to school opening. This is not easy. I think the consensus is we have to do school opening for the psychosocial development of our children, that children are a low-risk group, that we need to have strong mitigation measures and surveillance measures in our schools, and that we encourage all of the administrators to contact their medical advisors and their boards and their local health agencies. Definitely, it's a fluid situation. The situation a month from now may be totally different than it is today, and we'll just have to keep in touch. In terms of this program, we're going to try to do the same thing next week. In 2 weeks, we actually have a very interesting discussion, August 13th. It's going to be about the entrepreneur efforts in Armenia. You know, one of this crisis has really caused economic devastation We mentioned the NGOs when we started and how many NGOs, nonprofit organizations, will fail, unfortunately. But there might be government failures as well if the economy isn't started. So there are active efforts in Armenia to stimulate entrepreneurism. We're going to be hearing about those efforts from the Near East Foundation and possibly another group as well. So thank you again for tuning in. It's a pleasure having you with us, and we're here to serve. And I wish you all and your families a very healthy, happy week.